Hello, I am Dr. DAINI and I have been dealing with problems concerning the ocular surface for a very long time, ever since I was a resident in a renowned university eye clinic in Germany, in Essen, 1988. Already at that time we understood that the integrity of the ocular surface was very important in calculating the power of the IOL prior cataract surgery, which is actually a big problem. And following the years, we developed different tools to avoid dry eye disease or trying to limit it. But particularly now, in this pandemic era, we have observed a great increase of dry eye, especially because most of the people are forced to be literally staring in front of electronic devices and suppressing the rhythm of the natural eye blinking, decreasing from 22 times per minute to 8 or even 6 times per minute. This brings the ocular surface and all the anterior segment of the eye to blurring and scratching because of the thinning of the layer of the lacrimal film. As you all know, generally speaking, we divide into two big main groups of the dry eye disease patients. Hyperproductive, and it's a quarter reaching 25–30% of the people, and the vast majority of the cases evaporative dry eye. That's why we have a lack of the third layer, the lipid layer, which is practically a coat limiting the evaporation of the aqueous layer. For some years I have been using this tool. This tool made by the company Espansione is completed by a handle, as you can see here, and a mask. The general protocol, which has been taught to me, and it is very effective, is consisting in two parts. The first part is completely painless. We use this tool, and we put this tool very close to the underlid. We perform 5 eye shots, 3 eye shots underneath the lower eyelid, and 1 temporal, and the 5th one overlapping horizontally. And as I said, it is completely painless, and it can be modulated according to the severity of the type of the dry eye. It means that I have a scale in the software which I can decide, and I can put on a scale ranking from 1 to 4 in a Meibomian scale, and 1 up to 6 in the pigmentation scale. The highlight tool is comprehensive of 2 different devices. One is the handle and the other one is the mask. Stimulation of the Meibomian gland, and then I put the cartridge. As you see, I have a Meibo scale according to Dr. Palt from 1 to 4. Most of the people needs 2 or 3. One in case of a light chronic blepharitis, 2 or 3 if I have a manifest real chronic blepharitis, or 4 if I have a hypercalathiosis. Let's put 2, then I enter. I can read through this handle the pigmentation, the different kind of pigmentation of the patient. Let's put 2, enter. Here I can choose the power expressed in joule, and according to the joule and the power of the light spot, I can obtain the opening of the meibomian glands and the contraction and the shrinking of the telangiectasia. So the effect of this handle is to decrease the metalloproteinases, which are, as you know, pro-inflammatory enzyme, and at the same time increase the cytokine by developing the cytochrome C oxidase inside of the cells through the spots. The power of the spots, generally speaking, is according, as I said, to the severity of the disease. When I use the handle, I protect by the flash myself with these light protective glasses, and I protect with eyes wide shut the patient with this very simple eye protector. When that's over, I change the cartridge with a second one, which is connected directly by the cable with the mask. And this is the mask. The mask is covered in the inside by LEDs. Those are red LEDs emitting another kind of energy, which is a very, very thermic energy, because the wavelength is red, light modulation, and that's the treatment. The treatment is very easy. I place the mask, the patient has to keep the eyes shut for 15 minutes. This mask performs a particular kind of energy. This energy activates the ATP. Inside the cells, and gives new energy to the cells to produce the meibum, the cells of the meibomian gland. At the same time, reinforce the elastin and the connective tissue, so you can see after 3 or 4 or 5 treatments that all the tissues around the eye are straffer, are tenser and softer, and at the same time it goes right to the point, which is to interfere in the so-called melting range of the meibomian gland. Most of the meibomian glands are not only atrophic, but contains the meibum in a solid, specific consistency. Let's say like the butter just taking off the bridge. What I need to cover the liquid layer is a liquid lipid layer. So when I go to interfere in the melting range, which is around 42.8 Celsius, which is 108 Fahrenheit, I go exactly right to the point and I melt the meibum, make it softer and liquid, and that goes out and starts to cover, coating the rest of the aqueous layer and the mucin layer to protect and prevent the evaporation. So, at the end of the story, when do we use this tool? As I said, made by 2 different phases. The first one with the handle, which the proper intense pulse light, and the second, the mask, which is the LLLT, low level light therapy. I use it for the dry eye disease with meibomian glands dysfunction, because, as I said, I need to meet the melting range and soften the content of the meibomian gland. At the same time, I suppress the metalloproteinases of the matrix, and I restrict the telangiectasia of the lid margin, which are also pro-inflammatory. And if I increase the power of the stimulation of the both handle and mask, I can cancel from the collecting around the eyelashes the demodex. There are two other kind, to be specific, of masks. There is a mask emitting a blue light, which is more specific for Demodex, and there is another one with the yellow diodes, which is more specific for hydroretention around the eye. I have a large experience with the red mask and the handle since I use it. I have been used that for more than 2 years. So blepharitis, chronic blepharitis, Demodex, dry eye disease, and that is very important, calathiosis. I have several young patients which refuse to undergo surgery because of the scarring, especially young ladies. And when I use in a closer rhythm this treatment, I can obtain the regression, very big regression of the calathiosis. I use it. I use it for 3 treatments in simple blepharitis. Let's say the treatments has to be in a simple blepharitis performed every 2 weeks, 3 times. When the blepharitis is more severe, I make an intense frequency of the treatment, using that either twice a week with an interval of 48 hours between the 2 treatments. In calathiosis, even more. My last big calathiosis was a young man with 7 calathios, sparse in all the eyelids, and with only 4 treatments of handle of the IPL and the mask. I resolved everything without doing any surgery, and that's why. Because the calathiosis was relatively recent, it was new, and since I met the melting range of the meibomian secretum, I melted even the calathion, and I developed the pro-inflammatory, anti-inflammatory treatment through the mask. So I'm very happy with that. And remember that lately, especially in the pandemic age we are living now, unfortunately, the patients coming into our office with this problem are increasing more and more and more. And we are dealing with very different kind of problems, and they literally make a vast majority of patients. If you add to this problem the simplicity of the use, it is very convenient to treat the patients. And the last I would like to say is to prepare a perfect liquid layer before and after refractive surgery and cataract surgery. Remember, the first study we performed in Essen way back in the late 80s showed us that a perfect IOL calculation needs to have a perfect thickness of the eye layer, which consists generally between 200 and 300 microns. And that has the value of 1 diopter. So if you mislead everything and you perform an IOL mastering on a patient with dry eye, you might have problems post-operative because the calculation has not been done properly. The same is the calculation of what you want to ablate through a femtosecond LASIK or a PRK. You need to know the exact thickness of the layer because it converts everything in the post-operative results. In addition, you need to do that not only pre-operative, but mostly, in most cases, post-operative, because cataract surgery through the cut near the limbus makes a temporary interruption up to 9 months of the innervation of the basal lacrimation reflex. So most of the patients refer dry eye and itching and blurring and scratching, and that's the same after refractive surgery. So I recommend, if you have the big luck to have this tool and to make the patient satisfied, to use it prior the operation, refractive and cataract, and even afterwards.